Welcome. Previously, we discussed panoramic radiographs for plain film imaging of patients in the context of TMJ arthritic conditions. It is important for clinicians to rule out dental and/or local bone pathology that may cause pain symptoms that are similar to TMD, and many consider the panoramic radiograph extremely useful for this purpose. Panoramic radiographs are commonly used as baseline imaging for all patients with orofacial pain complaints. The use of advanced imaging modalities such as computed tomography or CT and magnetic resonance imaging or MRI must be selected judiciously by the clinician based on a number of factors, including specific patient complaints, clinical exam findings, and response to treatment. Both cone beam and medical CT are often utilized to evaluate suspected bony pathology associated with TMDs. MRIs are often utilized for soft tissue imaging of the TMJ and are considered by many to be the gold standard for advanced TMJ imaging. Clinicians ordering advanced imaging studies should be able to interpret the images and understand the findings in the clinical context of the patient's condition. The last part of our discussion on TMDs may be considered, by some, to be the most important. We will now review various treatment modalities for TMD. The types of TMD therapies we will discuss are based on conservative management principles in the general context of the biopsychosocial biobehavioral model of disease. Pharmacologic agents are often used as first-line therapies for TMDs. There are several classes of medications used to manage TMD symptoms, and agents may be used as monotherapy or in combination. Nonsteroidal anti-inflammatory drugs, or NSAIDs, are commonly used by patients and recommended by clinicians to manage TMD symptoms, and many of these agents are available without a prescription. Common NSAIDs that have demonstrated benefit in managing TMD symptoms include ibuprofen and naproxen. Muscle relaxants are often used for management of TMDs, and these are typically available by prescription. Common muscle relaxants used for this purpose include cyclobenzaprine and metaxalone. The most common side effect reported with use of muscle relaxants is sedation. Other pharmacologic agents that have shown some benefit for management of TMD symptoms include anxiolytics, such as diazepam, antidepressants, such as amitriptyline, and topical agents, such as lidocaine patches. Clinicians prescribing any of these medications should have a clear understanding of the risks and benefits of using these medications, knowledge of how these agents work, and be able to recognize and manage potential side effects and adverse reactions related to each medication. Another treatment modality often used to treat TMDs with generally favorable outcomes is physical therapy, or PT. Most clinicians are able to demonstrate basic forms of home PT for the TMD patients, which typically include hot and cold therapy and passive jaw stretches. If the patient is not receiving benefit from this type of PT or requires more aggressive PT, referral to a professional physical therapist trained in TMJ and masticatory muscle therapy is highly recommended. Common professional PT techniques include hot and cold therapy, passive jaw stretching, as well as ultrasound and transcutaneous electrical nerve stimulation, or TENS therapy. Many TMD patients receive substantial benefit from home and/or professional PT. Appliance therapy may be viewed as adjunctive therapy for TMD patients, especially if they have a demonstrated parafunctional habit. Patients typically yield the most benefit from this type of therapy using a hard, flat-planed, full-coverage appliance which is custom fabricated by dentists. Appliances that are fabricated to be worn on the maxillary teeth are usually used while the patient is sleeping due to a sleep parafunctional habit and are commonly referred to as night guards. Appliances may be fabricated to be worn on the mandibular teeth for both sleep parafunction and daytime clenching, as it is generally less bulky than maxillary appliances and minimally interferes with speech. Patients may report beneficial use of an over-the-counter mouthguard, typically sold in sporting goods stores or pharmacies, but these appliances are not recommended for long-term use due to the one-size-fits-all nature of these types of appliances. It is important for patients who have custom fabricated appliances to follow up periodically with their dentist for evaluation of fit and adjustments as needed to maintain the integrity and therapeutic benefit of the device. Trigger point injections to the masticatory muscles are often used as therapy for TMD. We previously discussed trigger points when reviewing TMD myofascial pain. Patients with trigger points receive injections to these areas, which often result in symptom relief for variable periods of time. Trigger points for the temporalis and masseter muscles are typically completed from an extraoral approach, while the intraoral approach is commonly used for the pterygoid muscles. The most common solution used for trigger point injections is local anesthetic. Clinicians who perform extraoral trigger point injections should be aware of the anatomical location of the branches of the facial nerve, as these may inadvertently get anesthetized during the procedure. Patients with TMD often benefit from treatment modalities that address Axis II conditions. As previously discussed, incorporating foundations of management in the context of the biopsychosocial, biobehavioral model of disease is beneficial for chronic orofacial pain patients. In this context, complementary and alternative medicine or CAM treatment modalities have been beneficial for patients with TMD. Relaxation training, biofeedback training, and cognitive behavioral therapy are management strategies previously discussed. Additional CAM modalities with limited evidence to support efficacy in management of TMD are acupuncture and hypnosis. Finally, it is reassuring to know that the vast majority of patients with TMD who require active treatment benefit tremendously from the conservative therapies previously discussed. Approximately 5% of patients with TMDs require invasive therapy to manage their condition because of poor response or lack of response to conservative therapy. Invasive procedures range from minimally invasive, such as joint injections and lavage, to major invasive procedures such as total joint replacement. Patients requiring invasive therapy for management of TMD should be referred to a healthcare provider with extensive training and experience managing these conditions in this manner. This concludes our discussion of TMDs. In the next segment, we will discuss trigeminal neuralgia, a type of neuropathic pain condition.